Today we will discuss hyperkalemia. As we already discussed, normal potassium level in the serum is 3.5 to 5.5 milliequivalent per liter, and hyperkalemia is serum potassium level more than 5.5 milliequivalent per liter. So hyperkalemia is further classified into mild, moderate, and severe. Mild is 5.5 to 6 milliequivalent per liter. Moderate is 6 to 7 milliequivalent per liter, and severe is more than 7 milliequivalent per liter. Then we came to causes of hyperkalemia. Causes, as we see, causes broadly divided into 6 reasons. That is excess potassium intake due to dietary supplements or due to IV KCl in hospitals, or due to decreased potassium excretions, that is due to CKD like renal impairment. And third reason are hormonal changes like in Addison disease where aldosterone deficiency is there, or with type 4 renal tubular acidosis. Fourth reason is intracellular potassium release, that is due to cellular release of potassium to the serum. It occurs due to rhabdomyolysis, that is muscle breakdown, tumor lysis syndrome, hemolysis, cell breakdown, RBC breakdown, and due to beta blockers and low insulin level. And fifth reasons are drugs like ACE inhibitor, potassium sparing diuretic like spironolactone, non-steroid anti-inflammatory drugs, heparin, cyclosporin, and tacrolimus. Sixth is pseudo-hyperkalemia. That is when potassium level actual potassium level is not so high, but is due to some error like hemolysis due to venipuncture. Now, now we come to sign and symptom of hyperkalemia. Sign and symptom varies from mild symptom like muscle fatigue, weakness, paralysis, to severe symptom like paralysis and palpitation and cardiac arrhythmia. Sometimes it is so fatal it lead to cardiac arrest too. Now come to ECG changes of hyperkalemia. Now first we see the normal ECG. Normal ECG with potassium, that is 3.5 to 5.5 milliequivalent serum potassium. ECG is PQRST wave. See these PQRST waves of ECG. Now in case of mild hyperkalemia 5.5 to 6.5 milliequivalent, there is tall T wave, followed by when serum potassium level is 6.5 to 7.5, there is prolonged PR interval, wide QRS complex, and of course tall T wave. When serum potassium level is more than 7.5, there is absent T wave and there is loss of all waves, that is sinusoidal pattern of ECG. Rest diagnosis we made with lab values, serum lab values of potassium, and with help of ABG. Now come to treatment of hyperkalemia. Treatment includes several steps. The first step is stabilize the cardiac membrane or myocardial cell membrane, which we do with the help of 10 ml of 10% calcium gluconate IV slowly over 10 minutes. This is calcium gluconate ampule. This is calcium gluconate 10 ml ampule. Each ml contains 50 mg of calcium gluconate. This we give over 10 minutes in 100 ml NS or slow IV push. The second step is redistribution of potassium intracellularly. That is like in case of cell breakdown, when potassium comes from cell to blood, then we give this measure. That is 100 ml D25 with 10 unit of insulin. This is known as neutralized dose. This we give fast to rapidly decrease the serum potassium levels. Or we can nebulize the patient with albuterol 20 mg for 20 minutes. This also shifts the potassium from serum to the cell. In case of severe acidosis, we give soda bicarb 1 milligram per kg IV push. This is also given fast. This is soda bicarb ampule 25 ml ampule. This we give IV push. Then third step is excretion of potassium, which we do with the help of Lasix or furosemide, also known as furosemide. 40 to 80 mg Lasix we give IV push. In case of refractory hyperkalemia, we consider hemodialysis. Now you see, these are the steps of hyperkalemia treatment. First we only stabilize membrane, then we shift the potassium into the cell, then we excrete the potassium from the body with the help of furosemide, or if this is also failed, then we consider hemodialysis. In mild cases, we can give K-pint sachet, which we give with 100 ml 20% sorbitrate, which we give orally only. Thank you.